Okay, so this is your recorded lecture for wound care and management. So risk factors for wounds include age, mobility issues, weight, and then other conditions such as spina bifida, cerebral palsy, and other chronic conditions such as liver, renal diseases, cancer, and malnutrition. So the reason that age is a risk factor is because as we get older, our skin loses the elasticity. Um, our skin becomes more fragile and thin, so it makes it a lot easier for it to tear. Decreased peripheral circulation, so decreased circulation to the periphery of the body, so the extremities, especially like the feet and the hands. It takes longer for the tissue to regenerate. There's decreased collagen. Also, they can have an impaired immune system and dehydration. Of course, overall wellness plays a role as well. So, wounds are going to heal better and faster in young and healthy individuals. If someone is malnourished, then wounds are not going to heal as well. So nutrition provides energy and elements of wound healing, especially if someone is low in protein, if their albumin or their protein level is low, it's going to be harder for that wound to heal. Of course, if we have decreased tissue perfusion, then it's going to be more likely to break down because the tissue is going to die. So this is especially what we think of with pressure ulcers, so that pressure being applied to part of the body that's causing decreased circulation. And then also things like peripheral vascular disease or patients who have diabetes. They have decreased circulation to their extremities, and this oftentimes leads to skin breakdown and even necrosis. So if someone is obese, it is going to be harder for their wounds to heal because that adipose tissue is not near as vascular. So it has decreased blood supply, so therefore it's harder for it to heal. Okay, so wound terms that you need to know. So maceration is an irritation of the epidermis or the top layer of the skin caused by moisture. Dermatitis is a red skin irritation that develops when the skin is exposed to irritants such as feces, urine, stoma effluent, and wound exudates. This specific type of dermatitis is called irritant dermatitis. So feces and urine, they have chemicals and things like that in them that is going to accelerate skin breakdown if it's on the skin. And then stoma effluent, this is if someone has an ostomy. So anything that's draining out of that stoma, if it's touching the skin, that can cause damage and breakdown to the skin. And then going back to maceration, so this is usually an irritation caused by moisture. So if the skin is staying moist, it's going to make it easier for it to break down. So that's why we want to keep our patient's skin dry. So skin tears is kind of what we were talking about with older adult skin. When their skin becomes really fragile, it's easy for it to literally tear. So this is loss of the top skin layer caused by mechanical forces. So if we're moving a patient up in the bed, those shearing forces can cause a skin tear. It can also be due to like blunt force trauma as well. So like a lot of times if an older person hits their arm on, a side rail or something like that, that could cause a skin tear as well. We talked about skin frailty. This is at-risk vulnerable skin. And pressure injuries are localized damage to the skin and or soft underlying tissue, which can be caused by prolonged contact with a firm surface that interferes with circulation to the area. And then cellulitis is an infection of the superficial layers of the skin. Okay, so types of wounds. So laceration. So this is usually caused or can be caused by blunt force trauma or by something sharp. This is typically, if someone hits their head or quote unquote busts their lip open, that's a laceration. Or if they have a cut or something from a sharp object, that would also be considered a laceration. Surgical wounds are obviously wounds that are done in surgery, so like incisions, in order to be able to perform a surgery. Moisture associated risk damage or skin damage is going to be like your maceration. Chronic wounds, some people will have chronic wounds, either pressure ulcers or diabetic foot ulcers. So moisture associated skin damage, this is a form of dermatitis when the skin is exposed to irritants like feces, urine, stoma content, and wound exudates. So kind of like what we were talking about earlier. And then chronic wounds develop over time as a result of disruption in the wound healing process associated with acute wounds or due to conditions that cause alterations in blood flow. These conditions include chronic venous insufficiency, peripheral artery disease, and diabetes mellitus. So we've kind of talked about that as well. All right, so delegation. So most dressings are not going to be delegated or dressing changes to unlicensed personnel. Really needs to be a licensed nurse that does this. And then, of course, if it's sterile, we know that we never delegate that. Sometimes unlicensed personnel can apply clean dressings to chronic wounds or reinforced dressings. But those are kind of special cases, and the nurse is still responsible for making sure that care is being done and done correctly. They must be reporting all of the findings, wound care findings, to the nurse. Okay, so purposes of a dressing. So they are to protect the wound and provide comfort, control infection, so to help keep microorganisms out of the wound. Also, it's going to help if there is an infection in the wound, it's going to help keep that from spreading anywhere else. It's good to absorb drainage. It also helps remove necrotic tissue if necessary. This is also known as debridement, and we'll talk more about this, but kind of as you change the dressings, a lot of times this causes debridement of necrotic tissue. It hides the wound from view, so the patient's not looking at it, or the family members are not having to look at it all the time, especially if it's a pretty gnarly wound. You don't want to be looking at that all the time. Also protecting the wound from further injury and then preventing bleeding. So we know that if we apply pressure, if someone's bleeding, that's going to help stop the bleeding. Okay, so nursing process. So whenever we are planning to do a dressing change, these are the things that we need to do. So we want to try to time dressing changes at a convenient time for the client if possible. They should be planned after and not before meal times because sometimes this can cause someone to have a decreased appetite, especially some of these wounds. If they become necrotic or gangrenous, they're probably not going to smell great. So we don't want the room to smell like that right before they eat. So just to help promote them eating and their appetite, we don't want to do this before a meal. If the client is experiencing pain, we want to try to help with this if we can. Some dressing changes are going to be very painful for the patient. So if we have pain medication ordered, we can try to give that to them before their dressing change is done. So if they do have some pain medication, we want to try to give it to them 30 minutes before we actually do the dressing change so that medication is working for the patient. If we don't have this ordered and we know the patient hurts a lot with the dressing change, then this would be a good time for us to advocate for our patient and call a physician and see if we could get something. And then, of course, we always want to provide privacy. Okay, so wound management. So there's really no standard frequency for how often a dressing should be changed. It depends on the amount of drainage, the practitioner preference, nature of the wound, and the type of product being used. So you will have orders, or you should have orders in the patient's chart for how to change and take care of the wound. But of course, this is going to be PRN as well. So even if it's maybe you just change the dressing once a shift, well, if there's a bunch of drainage or something and it becomes dirty, then we're going to change it again. We're not going to just leave that dirty. So if for surgical wounds, if someone has had, a surgery done, the first dressing is typically changed by the surgeon. So a surgical dressing is still considered sterile, typically 24 to 48 hours post-op. So if we do have to change it within that time period, it is going to be a sterile dressing change, but the first dressing change needs to be done by the surgeon unless directed otherwise by the surgeon. Remember, wound contamination occurs through moist medium. So like when we're talking about sterile field, we don't want it to get wet because that allows for microorganisms under the sterile field to travel up into the sterile field. Same concept with our wounds. If they get moist, it's going to cause all those little bacteria to be able to travel into the wound, or vice versa. So if the wound's infected, we don't want that to travel out and to where it can be spread to other places. So we want to replace any saturated dressings or reinforce if they can't be changed. So if we have a surgical wound and it hasn't been changed yet by the surgeon, it's still within that 24 to 48 hour period, then what we would do would be reinforce it. So just putting more of that same dressing over top of it to reinforce it and hopefully stop the drainage and prevent infection in the wound. Okay, so when we are removing a dressing, we are going to use standard precautions. So this is treating any bodily fluids or blood like it's got a bloodborne pathogen, even if we know the patient doesn't have that. We're going to wear our gloves. So, and why would you not want to, Okay. So put on clean gloves. Do not touch the skin or the wound. All right, so you're just removing the dressing, remove tapes and dressing in the direction of hair growth. Slowly remove the dressing, noting amount, type, color, and odor of the drainage. And then you're going to discard the dressing according to agency policy, remove gloves, and perform hand hygiene. Okay, so we're not only looking at the wound, we're looking at the dressing. We want to know what type of dressing was put on there. Seeing if it was consistent with the orders. We're looking at the drainage, noting the amount, color, odor, because this is going to give us a good clue into how the wound is doing. And then we'll dispose of that properly. Okay, so then when it's time to assess the wound, we want to know what the cause of the wound is. So this helps us to know what type of wound it is. How long has the wound been present? Is it a chronic wound? Is it an acute wound? Previous treatment and response. So has something been done previously to treat it, and was it therapeutic or not? Determine allergies to cleaning agents, dressings, or tape. We always need to do this anytime we're using anything on our patients. A lot of patients are allergic to like adhesives and latex. We want to assess their pain. So are they complaining of discomfort? And we want to look and see when their last pain medication was. And if we can give it to them, we would like to try to do that. And then we're going to look for signs of systemic infection, so fever, chills, potentially vital sign changes if it's getting really bad. So we want to watch for that because that could progress from an infection in the wound to a widespread systemic infection. Okay, and then we want to assess and document what the wound looks like. So where is it at? What is the size, shape? Are the edges well approximated or are they jagged? Color, temperature, do they have drains? Do they have staples, sutures, or tubes? For the staples and the sutures, we want to count how many. What does the skin look like around the wound? Is it intact? Or is it red, swollen, bleeding? Is there any type of odor coming from the wound? And then we want to note the drainage. And we're going to talk more about this, but how we're going to describe our drainage is either serous, sanguineous, serosanguineous, or purulent. Okay, this is a picture of a surgical wound with well-approximated edges. So you can see it comes together really well. It's not jagged. Really, there's minimal bruising there. It looks really good. And so when we're charting that, we would want to measure it, note where it's at. There's no drainage, edges are well approximated, and then note the amount of staples present. Okay, so surgical wound complications. So we're going to talk about dehiscence and evisceration. So these are two things that are typically could happen when someone has an abdominal incision. So if they've had some kind of abdominal surgery. So dehiscence, this is the separation or splitting open of layers, of the surgical wound, okay? So over on this picture on the right side, you see A, this is dehiscence. So with dehiscence, the muscle is still intact, okay? But these other layers have come open. Evisceration, this is when same kind of concept, but the muscle is separated as well. And then this is causing the internal organs or your intestines to be outside of the wound. Evisceration, think of visceral, it's just related to internal organs. So that is how you can kind of tell those two things apart. Okay, so a lot of times with these, you can suspect that this has occurred if a patient has coughed or sneezed or something like that, and they say they heard or felt a pop in their abdomen. Okay, at that point, you're going to be suspicious that either a dehiscence or an evisceration has occurred. Okay. There also may be an increase in like serosanguineous drainage or kind of like bloody or pink drainage. So what do we do if this happens? So both of these instances are emergencies. So we need to let our physician know. But if our patient has an evisceration specifically, we're going to go over that, but it's going to be different than with the dehiscence. So risk factors associated with these complications are kind of the same risk factors for people who are more likely to have decreased wound healing or who are at risk for skin breakdown. So chronic disease, advanced age, obesity, abdominal cancer, vomiting, excessive straining, coughing, or sneezing, abdominal surgery, and infection. So the reason that we want to note the vomiting, excessive straining, coughing, sneezing, that increases that intra-abdominal pressure. So that's usually what leads to this. Okay, so nursing interventions, all right? So if we suspect this has happened to our patient, we've assessed, we see that it has happened, they've either got a dehiscence or an evisceration. So we're going to call for help and notify the physician if it doesn't require us to leave. Okay. We can hit the call light, call on our some way call someone and ask for help because we want to stay with the client at this point, and notify the physician. Okay. If there are protruding organs, we are going to get sterile towels or gauze soaked with sterile saline. Okay. And then we're going to cover the organs with that. Okay. So this is going to decrease the chance of bacterial invasion and drying of the tissue. So remember, our skin on the outside of our body is supposed to stay relatively dry, and then the skin on the inside of our body is supposed to be moist. Okay. So that organ is not where it's supposed to be. We want to keep it moist and protect it from any infection, any bacteria. Okay, and then we're going to position the client supine with the knees bent, and we're going to look for any indications of shock. So this would be like a weak, thready pulse, diaphoresis, paleness, vital sign changes, so blood pressure going down, heart rate going up. They might have increased respirations. We want to try to keep them calm because they're probably going to, be kind of freaking out. And they need to be in PO because they are probably going back to surgery. So some ways we can do to prevent this. So we can use like a pillow or like a folded up blanket to splint the abdomen. So if the patient does have to cough or sneeze or whatever, they can kind of splint that, and that's going to help displace some of that pressure. So to keep it from causing that wound to come back open. Kind of just provide support for that wound. Okay, so different drainage. Okay, so serous, that's our straw-colored fluid, kind of clear or straw-colored. Sanguinous is bloody. Serosanguinous is a combination of the serous and sanguinous, obviously. And so it's going to look a little bit more pink in color. And then purulent, that can be either or green or yellow, kind of thick. That means we've got an infection going on. And then purosanguinous would be like red tinged pus. And you need to know what these are, okay, and how they present. All right, here are just some pictures of different types of wounds that you might see. So up here we have what is called undermining, okay? So this is when the wound kind of goes deeper, tunnels deeper underneath from where we can really see. So skin breakdown has occurred right under that skin layer, but they've got this applicator poked in, and so they're marking where this extends to, okay? Here is just a way to measure the wound, how you would measure the length, width, and depth. Over here is a surgical wound. Again, it's got some bruising, but otherwise looks okay. Looks like it's well approximated. These are some different types of sutures, and then C looks like a dehiscence, okay? Down here on the left, this looks like this surgical wound has become infected, okay? So you can see that the edges are not really well approximated. There's swelling, redness. I'm sure there's tenderness and heat to that area as well. And then over here would be someone who's had a abdominal surgery, and this would be some serosanguinous drainage on this. Now, if they were just right back from surgery, hadn't had their first dressing change done by the surgeon, then this would need to be reinforced. Okay, so different types of things in the wound. So remember red, yellow, and black. So red is your granulation tissue, and you want to protect that, okay? So that's your red, kind of pink. It almost has like a cobblestone appearance. This is your good tissue, your good, viable, healthy tissue. We want to protect that. Yellow is slough, and we want to clean that. We want to clean that out of the wound. And then black or eschar, we want to debride it, okay? We want to remove that from the wound, okay? All right, so some basic guidelines for wound care. If a wound is clean and has little exudate or drainage and reveals healthy granulation tissue, we don't want to repeatedly clean it, okay? Because we don't want to disrupt that granulation tissue. Oftentimes, we're going to use gauze squares to go over the wound. You want to clean superficial, non-infected wounds by irrigating them with normal saline. And to retain wound moisture, avoid drying a wound after cleaning it. So if you've just irrigated with normal saline, we're not going to go in and dry that wound. We can dry the skin around it, but not the actual wound. Because remember, it's supposed to be on the inside of the body, so it's supposed to be moist. If there is a drain present, the main surgical incision is considered cleaner than the puncture wound, okay? So then we would always clean the incision. So we go clean a dirty, clean the incision before moving on to the drain site. All right, so when is a dressing clean versus sterile? All right, so sterile is after surgery. It's left on for 24 to 48 hours. It's changed using sterile technique. Clean dressing is 48 hours post-surgery. Pressure injuries, or skin tears or chronic wounds are all just clean. Okay, so there are different types of drainage systems. So the Penrose drain, this is an open drainage system. Typically, this will just have a drain or a dressing over it. Your closed systems are the Jackson-Pratt drain and the Hemovac drain, and we're going to talk about these. So this is a picture of a Penrose drain. So as you can see, it's open. It's usually going to be on something that's kind of like draining. We're trying to drain the fluid out, that's what all of these are basically doing. But it may be on like an abscess that's been drained or whatever. But this is what it looks like. You just want to keep it clean and keep a dressing over it. Okay, and then a Jackson-Pratt drain. So this is your closed system. So it's a little bulb. So a surgeon will place it or a physician. And you want to make sure you're monitoring the drainage that comes out of this. So what this does is it's a little bulb, and you take the little plug out of the top, squeeze the bulb, and put the plug back in, and this establishes suction. Okay. So this causes that negative pressure to drain the fluid from the wound. We want to make sure that we empty this at least every 8 hours, okay? If not more. So whenever the fluid or whatever gets about 2/3 of the way full in the bulb, we want to empty it, because then our suction is no longer going to be in place because that bulb is expanded. So then we want to empty that. We want to measure it, note the drainage, chart it, all those things. And then we want to reestablish the suction. So we're going to squeeze the bulb and place the plug back in it. Okay, Hemovac drain is the same concept. It just looks a little bit different, okay? It's a closed system. It kind of looks like a little accordion. You establish that negative pressure or suction the same way. You're just going to squeeze it down, put the plug in it. Same thing with the drainage. When it starts to get about 2/3 of the way full, we're going to empty it out. You can see in this picture here, they're measuring the drainage in a graduated cylinder, and then when they get done, they're going to squeeze it back down and put that cap back in it. Okay, so important things with drains. We want to be careful not to dislodge them, so we don't want them to be accidentally pulled out or the patient accidentally pull them out. Monitor for character and amount of drainage. Report any significant changes. So, if we were having, only to empty the drain maybe every 4 hours, but now we're having to empty it every 30 minutes, that's been a pretty big increase in our drainage. So we want to note that and report that. We also want to just make sure that it is draining appropriately, and if we think there's like a clot or some kind of occlusion in it, we want to just note that, and we might need to let the physician know if we can't get that to start working right, and then maintaining suction as well. Okay, so these are just different securing dressings, different things that might be used. All right, taping considerations. So if someone has excessive hair, one, it's gonna hurt because when you pull that tape off, it's gonna pull their hair out. But two, it's not really gonna stick to the skin. So if you have, a dressing that you're having to do over an area that's kind of hairy, then you could get some clippers and kind of clip that hair so that the dressing stays secured. If someone is diaphoretic or sweaty, obviously that dressing is not going to stick very well. And then fragile skin, so like our older adults, usually it's good to use like paper tape. It's a little bit easier on the skin because some people that have really, really fragile, thin skin, even just pulling tape off can cause like a skin tear. And then, of course, we always want to assess if someone is allergic to any kind of adhesives or anything that we are putting on them. Okay, this is a picture of a wound vac. So you may see this in the hospital. So this is something that's put in during surgery. So this is when an incision is left open. And there is like that black part is like a sponge that they cut specifically to fit inside of the wound. And then they put a Tegaderm over it, and the wound vac is attached. Okay. So this helps speed tissue generation. It decreases swelling. It enhances healing in a moist, protected environment. So the drainage goes into the side canister here. And if once it gets full, it'll usually beep at you, but you'll just change out that canister there. If any of this becomes, compromised in any way, it's probably not going to maintain the suction. So if there's a hole in the Tegaderm or something like that, and usually that sponge will start to kind of puff up. So this is what it should look like. If it looks different than that, then you need to let your healthcare provider know, or a lot of facilities have specific wound care nurses that can come and help you with that. Okay, so pressure injuries. So this is localized damage to the skin and or underlying tissue as a result of pressure or pressure in combination with shearing forces. So friction. It most often occurs over bony prominences, but can also be a result of pressure caused by a medical device, such as urinary catheters, oxygen tubing, endotracheal tubing, or drains. So that's why we want to be mindful of this. So any prolonged pressure at any point on the body can lead to a pressure injury. But the most susceptible areas are bony prominences such as the heels, toes, sacrum, hips, elbows, shoulders, and back of the head. Okay. So pressure injuries are classified according to how much tissue loss is observed. So nurses assess how deep the tissue loss is and stage or classify the wounds using a scale of 1 to 4 based on the level of tissue loss. All right, so stage 1 is a non-blanchable erythema of intact skin. Okay, so this is a reddened area, but it is non-blanchable. That means that if we press on that reddened area, it is not going to turn white and then turn back red. Okay, it's just going to stay red. All right, so that means we've got decreased perfusion there. We're in stage 1. Okay. Stage 2 is partial thickness skin loss, and we have the dermis is exposed. Okay, so at this point, there is officially impaired skin integrity or skin breakdown. All right, stage 3 is full thickness loss. So at this point, you can see the adipose tissue or the subcutaneous tissue. And then stage 4 is full thickness skin and tissue loss. At this point, you could see muscle, tendon, or bone. Unstageable, this is just when you can't see how much skin is lost because it's obscured usually by eschar, that really hard black necrotic tissue. There are also deep tissue injuries. So these are persistent, non-blanchable, deep red, maroon, or purple discolored areas, but they're not necessarily, there's not necessarily breakdown on the surface of the skin. Okay, and then here's a good visual here. So stage 1, non-blanchable. Stage 2, we can see into the dermis. Stage 3, we're down to the subcutaneous tissue. Stage 4, we can see muscle, tendon, or even bone. Here, if it looks like this, we suspect a deep tissue injury. Okay. The skin will feel kind of boggy. And then unstageable, you see you've got this eschar, you've got this eschar here, so you can't really determine how extensive the tissue loss is. All right, so factors that influence wound healing. So we've kind of talked about some of these: diabetes, infection, drugs. So some medications cause decreased circulation to the extremities, especially if someone's in the ICU and they're on vasopressors. Obviously, tissue necrosis, hypoxia, if they've had extensive tension on an area, another wound, and then low temperatures. So think of like frostbite and things like that, where people lose their toes and fingers. That's due to their not having circulation to those areas because those vessels are so clamped down trying to warm the main parts of the body. All right, again, documentation. We want to note the location of the wound, dressing, what it looked like, assessment of the wound, were there sutures, staples, or drains. Note any abnormalities, document what you did, so cleansing and medication if ordered, and then type of dressing applied, was there any education that was done, how the patient tolerated the procedure, and then if they were treated for pain. Okay, so some wounds you are going to have to pack. So this nurse here is doing what's called a wet to dry dressing. And they are making sure all the surface of the wound is covered. So it looks here like this patient may have some undermining, like we talked about earlier. So where the wound kind of extends under that layer of skin. So that's why we want to use some kind of applicator to make sure that our sterile gauze is touching all parts of the wound, okay? So typically what we will use is like, we always called it Curlex, but basically a big long strip of gauze. We get it moist in sterile water and then bring it out after we've cleansed the wound. Then we place this on there, okay? And we make sure we use the applicator and again, get all surfaces of the wound bed covered. So we may have to kind of push some of that gauze into the areas where it's kind of tunneled or undermined under the skin, okay? So you've got this moistened and then you will, once this is all in there, you'll do probably some just dry gauze and then some kind of other occlusive dressing to go over the top of it. Then this gauze will dry. And so when you change it, you will pull that gauze out. And because it's dried and kind of stuck to that tissue, it will help debride or pull off any of that necrotic tissue or slough that we want to get off. Okay. If we do have to obtain a wound culture, so if we think the wound is infected and we have an order for a wound culture, we'll use one of these swabs. The swab only needs to touch the granulating area, okay? So the granulation tissue, which is the pink moist tissue, okay? We're going to avoid the wound edges. We don't want to swab any areas of slough or eschar or any exudate, okay? So we're not just like sopping it around in the exudate. We're going to just touch the granulation tissue, okay? Do not swab multiple sites with the same swab. Once we have swabbed, we're going to put it back in the little container here, crush the ampule, and then label and transport to the lab. Okay, so wound debridement. This is the process of removing dead tissue and other debris that can cause infection in the wound. During surgical debridement, accumulated debris, also called biofilm, and dead tissue are removed with a scalpel or scissors. So this is what you see in this picture up here. Debridement decreases the number of bacteria in the wound and stimulates the rebuilding of the wound bed by contraction and epithelialization. So that's what the sharp debridement is there. Nurses, unless you're like an advanced practice nurse, you're not going to be doing this type of debridement, okay? Now mechanical debridement, so that's kind of what we talked about with like the wet to dry dressings or wet to damp dressings. Hydrotherapy, this is, sometimes they can do like a pulsatile lavage or like flush with suction. And this may be used to promote wound cleaning and debridement in pressure injuries. And then there's also the option of enzymatic debridement. So this would be something that would be ordered by the doctor or maybe the wound care team. And so this just uses ointment that has enzymes in it that debride the wound. So you would clean and then apply the product and then cover it and then change the dressing once or twice daily. Okay, so if we have to reinforce a dressing, this will be if a dressing is following surgery, there's usually very little wound drainage, maybe some seepage, that would be normal. If a dressing becomes saturated though, so it's got a lot of drainage on it, it can be reinforced with additional ABD pads or abdominal pads, okay? The number of saturated dressings must be recorded and reported to the surgeon, okay? So if you just keep reinforcing and it still is becoming saturated, we need to let the surgeon know this, okay? But we're not going to remove the surgical dressing without a doctor's order, okay? So something to note here too is primary and secondary intention healing, okay? So primary intention, this is when there's little to no tissue loss. Edges will be well approximated, so your surgical incision. It should heal rapidly, low risk for infection, and then no or minimal scarring. And then secondary intention, so this is when like a wound is left open. So in the case of like if they have a wound vac, this would be the case, or if the wound is just left open, so it's not sutured closed. So this is when there's a loss of tissue. Wound edges are widely separated, they're not approximated. This could be from a pressure injury or open burn area. It typically takes a long time to heal. There is an increased risk for infection. There's excessive drainage and tissue debris, scarring, and then it heals by granulation. So it kind of heals from the inside out. All right. So bandaging extremities. So if we need to bandage somebody, these are just some guidelines we need to follow. So if we're bandaging a body part, we want to kind of put it in its normal position with the joint slightly flexed. Before applying elastic compression, be sure the limb is not increasing in edema. So if the limb is starting to increase in edema, then we would get worried for something that's called compartment syndrome. Pad, we want to put a pad between the skin surfaces over bony prominences, of course, to prevent skin breakdown. We want to work from distal to proximal. Leave the end of the body part exposed. Cover dressings at least 5 centimeters to 2 inches beyond the edges. And we want to face the client when we're doing this so that we kind of maintain the uniform tension when we're placing the bandage, so we don't have it super tight in one area and loose in another area. We've kind of got a uniform, amount of tension around that extremity. Okay, so sometimes we will remove sutures, of course, if the doctor has ordered it. So some guidelines for this, we want to cleanse the wound or surgical or suture line. We're going to use forceps to pick one end of the suture, and then slide the scissors under and then gently pull in the direction of the knot. Okay, so most hospitals will have like suture removal kits. So they'll have like the little scissors that have like their shape to where they can kind of real easily go under the sutures. So this is a picture of really easy sutures to remove. Okay, sometimes they're kind of tight to the skin and they're hard to get, but we want to have our forceps over the knot, and then we're only going to cut on one side. Okay, so we just cut that one side and then we pull up and the whole stitch should come out. If we cut both sides, that suture is going to be stuck under that skin. Okay, so we only ever cut on one side and then pull up. And it should come out and not be too terribly painful for the patient. Okay, and then removing staples. So there are like staple, I just realized that said staples. We're talking about staples. You can use like these special scissors. So you're going to lift up slightly on the staple and then squeeze and lift. And then you want to remove every other staple and then get the ones remaining, just to kind of help make sure everything is staying together, which it should if you're removing staples.